Shonali, it's over to you.
Hello, everybody. Hi, everybody. My name is Shonali Johnson, and I am the Head of Knowledge, Advocacy and Policy at the Union for International Cancer Control. And I just want to welcome you all today to this special focus dialogue, which is a collaboration between the UICC, the Wellcome Trust, the Norwegian Cancer Society, and REACT. Last year at London Global Cancer Week, we talked about the importance of raising awareness among the cancer community on this issue. And we will also draw attention to ensuring access to the right treatment at the right time. And that really is the focus of our discussion today with our title, Cancer Patients Are the Most Obvious Victims of the Superbug Crisis, and how do we ensure access to the right treatment at the right time to address AMR? AMR, antimicrobial resistance, is a growing public health issue that needs urgent attention globally. Without working antimicrobials, including antibiotics, routine surgery and life-saving treatments like chemotherapy can become life-threatening. And it's estimated that at least 750,000 people die each year from drug-resistant infections. So clearly, this is an absolutely huge problem for us, for our community and other communities. People with cancer are more susceptible to hospital-acquired infections due to the lowering of their immune defenses. Pneumonia and sepsis are among the most frequent causes of admission to intensive care units for cancer patients, and it's estimated that 8.5% of cancer deaths are due to severe sepsis. Antimicrobials are a key and indispensable part of cancer treatment. However, access to appropriate treatments, medicines and diagnostics for infections are not always a given and is a major problem globally. And this is why we are here today to talk about this during London Global Cancer Week. And as you may see, myself and my colleagues who are speaking today, we are all wearing blue. And blue has been chosen as the color for AMR awareness. And this week is the World Antimicrobial Awareness Week, Antimicrobial Resistance Awareness Week. And we are all here in support of that. So without further ado, I'm going to introduce you to our speakers. Unfortunately, Scott Howard, due to unforeseen circumstances, was unavailable to attend today, but some of his session will be covered by Dr. Anna Zozette, who will be the first speaker in this panel. And just to introduce a few of the things that we will talk about, we're going to be talking about sustainable access to and rational use of antimicrobials and diagnostics to address AMR. We're going to be talking about developing a new approach to financing, coordinating, and collaborating on R&D for new antibiotics and diagnostics. And we'll be looking at a consensus on strengthening collaboration towards finding novel solutions and in the implementation, which is always really important, of novel solutions. So I'm going to now hand over to Dr. Anna Zozette. Anna has a PhD in medical microbiology with a focus on antibiotic resistance from Uppsala University. She has been working for the global network REACT, Action on Antibiotic Resistance, in 2011. She was director of REACT Europe for 7 years and now serves as a strategic advisor. Anna will talk about the importance of addressing AMR by ensuring access to timely treatment, especially in LMIC. And just as we're speaking, all our speakers are going through their presentations, please do post your questions in the Q&A box, because we will have a Q&A session at the end. And I would just remind all listeners, please, can you mute your mics? Thank you very much. Over to you, Anna.
Thank you so much. And thank you for inviting me to speak here. As Shonali mentioned, Scott wasn't able to be here, so I'll improvise a little bit on his session as well. But first, a few words about REACT. We're an international network. We have offices in 5 different parts of the world: Sweden, Zambia, India, Ecuador, and the US. And we are quite a small network, around 30 individuals, and we're everything from physicians, microbiologists, to journalists, public health specialists, and communicators. So we're working with the question of antibiotic resistance towards our vision, a world free from untreatable infections. Next slide, please. Since Scott was unable to be here, I'm actually going to just say a few words of what is antibiotic resistance or antimicrobial resistance. it might not be completely familiar to everyone here. So it is the ability of bacteria or viruses or fungi or any other microorganism to withstand antibiotic treatment. So normally the antibiotic would cure you, but if in the case of resistance, it doesn't. And this is actually a natural phenomenon which occurs in nature all the time. However, when we use antibiotics, we select for those organisms that are resistant, allowing them to multiply and spread. And that is why we have to be cautious, only using antibiotics when they're absolutely needed. And I just wanted to take a few minutes to just talk about then how does resistance impact cancer care? It's actually on multiple levels, but both for treatment of infections, which I mentioned, and Shonali also mentioned bloodstream infections or sepsis, other healthcare associated infections, wound infections that occur a lot for cancer patients who have lowered immune systems, but also prevention of infections. Some treatments require a lowering of the immune system, or for some like chemotherapy, it's the consequence of it. And also in some surgery, as with all surgery, cancer surgery are prone to develop infections which have to be prevented with antibiotics. And just to give you one little example of, or one patient's story, it's quite a sad one, actually. Unfortunately, it's from the US, from a girl who was called Meredith. She was diagnosed with acute myeloid leukemia in her senior year of high school, and she actually beat the cancer. She went through chemotherapy, a bone marrow transplant, but then she got a localized infection under the arm, and it doesn't sound like much, but actually the infection persisted. And she was giving antibiotic treatment, several different kinds, and eventually one that's a kind of last resort antibiotic, but the infection spread and ultimately caused sepsis and septic shock. And she unfortunately died before starting university. And this story is shared at the CDC site. The parents have consented because it's described as after beating cancer, our daughter died from a superbug infection. And I think that's really what we're trying to avoid with raising attention to this subject also within cancer societies. Next slide, please. So my original talk was to be focused more on low and middle income countries, because obviously while the risk of getting cancer generally is higher in richer countries, the risk of dying from cancer is higher in poorer countries. And 70% of all cancer-related deaths occur in low and middle income countries. And unfortunately, people living in low and middle income countries are also the most affected by resistance, because of the associated costs, but the less access to infrastructure, access to medicines, which I'll talk to you a bit more in a second. And of course, access to advanced and basic cancer care and treatment. And some numbers is shown from Brazil, which is not the least developed country for sure, but still, quite a modern Brazilian cancer hospital reported that more than 60% of patients with resistant bloodstream infections died before they received effective treatment. And they saw that the ones that got it in time, within the first 48 hours, survived at a much higher rate than others. So it's also a matter of speed. And that's where we come in with diagnostics, like knowing which resistant infection you have to deal with makes a really big difference. Next slide, please. So what we in REACT often talk about is sustainable access to effective antibiotics. And what do we mean by that? It's actually kind of a three-pronged approach. Obviously, we want to preserve antibiotics, use them only when needed, as I mentioned, since all use of antibiotics drive resistance. So we want to minimize resistance. But we also want to ensure we have robust supply chains and an environmentally friendly production, because release of antibiotics from hospitals or from production facilities also facilitate spread of multi-resistant bacteria. And finally, we also want them to be accessible and affordable for everyone in need, because that's the ultimate goal of developing drugs and treatments, that the patient actually benefit from them. Next slide, please. And unfortunately, with regards to the last point on affordability and accessibility, the current model is set up with a market that gears research and development towards where the market potential is, i.e. the ability to pay, rather than the actual global health needs or the public health priorities. So what we need in the case of antibiotics is a way to kind of break the link between research and development costs and recuperation of these costs. So we need to make sure antibiotics have no misaligned incentives so that they're not oversold or overmarketed, whether it be by companies or by individuals earning a profit from them, such as doctors and veterinarians, pharmacists, and kind of in the informal market, but also as a way to make sure they're affordable so that they're not, as for example, for certain orphan drugs, priced out of the range of many people. I can just give an example of a REACT colleague of mine in India showed in his PhD thesis that secondary or tertiary treatment of resistant infections in India costs as much as a whole year's wage for a rural male Indian worker, and that's obviously not going to happen. So they will have to go without the treatment. Next slide, please. So what can the cancer community do? And this is my final slide. I think that cancer societies have a really important role to play. I've listed a number of things here that can be done. We need them to advocate for data collection and surveillance, collecting data on the impact of resistant infections on cancer patients, because we actually don't know the full extent. We know, obviously, they are affected. We know somewhat of the distribution, but we have no real understanding of actually how widespread this problem is, because often when patients die of resistant infections, that's not actually listed as the cause of death. It's listed as they succumb to their cancer and there were complications. So we're kind of in the blind here a little bit. I already mentioned access to treatment. We need to make sure there's available, affordable and sustained access to quality assured medicines and diagnostics, especially in low and middle income countries, because they face this triple burden of more prone to succumb to resistant infection, less able to pay for cancer treatment, less able to pay for antimicrobials. And that's really the unfair situation we are in today that we need to address. We also need to make sure that we develop new and affordable antimicrobials, and we have to do this within this de-linked model, because we cannot have the market steer this. Governments need to step in, but we also need to make sure that when governments step in, that they retain control so that the resulting research projects or antimicrobials become affordable for everyone. And for this, we need political engagement. That's where cancer societies all can play a really big role. Politicians, as we know, focus on the issues of what their constituents care about. So if we can get a higher political push for the need to address antibiotic resistance and access to effective antibiotics, especially in a kind of post-COVID world, I think that's really something we need to do. And on a more practical level, we could streamline in the need for effective antibiotics in national policy documents like national cancer control plans, because often they're not even really considered part of cancer treatment, but they really play a very crucial role. Next slide, please. So just thanking everyone and hope we get a lot of questions and a great discussion afterwards. Thank you.
Thank you so much, Anna. You've really raised some very key points, and I do hope that we can have a robust discussion on those. Thank you very much for highlighting the real impact that AMR has on cancer patients, and the story of this young lady, this young girl who really was poised to go to college and actually had survived cancer, only to be to lose her life to a resistant infection is very sad and does happen in many places. And the point you make about that surveillance is key, because I think it's very important for us to get a sense of the magnitude of the problem. We do know that it is a big problem, but it would be very interesting if our audience, if those participating in the call, could also make their reflections on AMR within their context, and it would be great to have a discussion on that. With that, look forward now to hearing from Diane Fleyhart, who's our next speaker. Diane is the Global Program Lead for Antimicrobial Resistance at Becton Dickinson, Becton BD. She works to champion and support the development of new antimicrobial resistance AMR program initiatives in global awareness, infection prevention and control, and antimicrobial stewardship. Diane also leads efforts for the Antimicrobial Resistance Fighter Coalition, which was mobilized by BD. Diane is going to talk about access to and rational use of existing treatments and the need for R&D for new and appropriate medicines and diagnostics. Over to you, Diane.
Thanks, Sonali, and thank you for having me join today. Next slide. So to set the stage a bit more, Anna did a great job in talking about AMR, what the problem is, and really, it's a challenging problem because part of it is we don't have enough antibiotics in the pipeline, and antibiotic use continues to go up. So there's some data that showed between 2000 and 2015 a 65% increase in antibiotic use globally, of which it's estimated anywhere between 15 to 88% of those antibiotics were perhaps inappropriate or not necessary. So we definitely have an overuse story when we talk about AMR. This is why we're seeing such a large increase of drug-resistant organisms. And even with the COVID-19 pandemic, we saw that as well, where we saw increased use of antibiotics initially, and we saw an increase in hospital-acquired infections and drug-resistant infections. So that's part of the discussion around, do we have the right antibiotics to use? But the other challenge is lack of access. So it's estimated that of the 5.7 million antibiotic treatable deaths in low to middle income countries are due to lack of access to antibiotics. So we don't want to use antibiotics too much because it causes more drug-resistant infections. However, we also have the problem that we don't have enough antibiotics to use where they're most needed. That's also true for diagnostics. So diagnostics are the tools that are used to inform the clinician of what the patient is infected with. And technology has grown dramatically over the past 20 years. We now have rapid molecular technologies that can detect a pathogen in hours versus days. We have automated platforms that can allow you to have a hands-off approach and improve time to detection and time to result for bacteria and their resistance markers. And then we have point-of-care technologies that are in your pharmacy, in your doctor's office, that can help inform your clinicians whether you need antibiotics or not. So with all these advances that we've seen, which are fabulous and are having a direct impact on AMR, we also just recently saw a report from the Lancet this summer that noted that 47% of the global population has little or no access to diagnostics. Now that is a very general diagnostic for all sort of healthcare, not specifically for AMR. However, I think it does reflect that we need to be aware when we talk about AMR and access, is really how do we balance getting the right technologies to the right locations to then allow us to use those antibiotics we have today and the ones we'll have in the future more effectively. Next slide. And this slide is showing kind of the need for diagnostics. Why do we need diagnostic tests? It's estimated that 30% of outpatient antibiotic use in the US is unnecessary. Over 50% of patients who have a viral infection receive antibiotics. And antibiotics only work against bacteria. So this is an example of misuse where we don't need to be using an antibiotic for that patient. And in fact, that if 1 in 5 cancer patients undergoing therapy have a bacterial infection, they need the antibiotics to be available to treat that infection. Much like the story that Anna shared, antibiotics are a critical tool in managing patients and their cancer care. And diagnostic tests really spread from how do we collect a sample to how do we test a sample. And then what happens with that result when, we all now, I think with COVID, all of us know about diagnostic testing. We all understand nasal swabs and that these swabs go into different types of tests. For AMR, what happens when these samples are collected, we know the specific organism causing disease. We know what antibiotics will work against that infection. And that allows physicians to have a very targeted approach. So they may start with lots of antibiotics that are very broad. Using a diagnostic test, they can then target those antibiotics, thus saving those other antibiotics that are not needed. Next slide. And the use of diagnostics doesn't just impact that specific patient. There are other areas as well. Infection prevention and control is critical to slow the spread of drug-resistant infections, and diagnostics inform where those resistant organisms are, with either in the healthcare center or in the community. There's also surveillance and reporting, which is so important to know how many bugs are where and when. So if we don't have the numbers that inform us about where the resistant organisms are, we can't then go in and run a program to make an impact. So really diagnostics are not just from a antimicrobial stewardship perspective, but also support infection prevention and surveillance, 2 other key pillars for AMR. Next slide. And this is just to show an example of now we know we need to improve access, especially in low to middle income countries. There's many programs available to help do that. And this is just an example of 2 programs. One is the Fleming Fund, which is a UK aid program, which provides grants, which allows diagnostic equipment to go into laboratories. BD, the company that I work with, had the opportunity to be awarded some of those grants. And when we go in to place the instrumentation, a key component is the training and what we call train the trainer. So we want to make sure we're developing lab capacity with talented microbiologists who will then train other microbiologists. So then the equipment there in that country can be used effectively and inform, as I said, surveillance as well as patient care. Another gap we see is when laboratories may have equipment available, but they've lost the trained staff. So the London School has a AMR MOOC, which is a massive online open course, which means you can access that and do training about best practices in the laboratory and how diagnostics can be used to combat AMR. And I pulled some numbers there. And as of for the past, it's been launched since 2019, and they've had over 11,000 participants. So a great program to really expand knowledge about AMR. Next slide. And quickly, I was asked to talk about, is there a need for R&D? And certainly there is. I think we kind of have shown the numbers and the impacts. This report was just published yesterday. It's from the AMR Industry Alliance. It is a group of companies from organizations from around the world in the life sciences industry. Is not inclusive of all life science industry companies, but there's 53 members. And just a couple of numbers to pull out. When we talk about R&D, they reported that between $1.8 to $1.9 billion has been invested in AMR-related R&D annually over 19 and 20. There's 93 new products being developed. And what I see exciting about this is it's not just one tool. It's antibiotics, it's vaccines, it's diagnostic products. And that's what we need. We need all those pieces to combat AMR. They're actively supporting access, so getting product in country. And another last part is appropriate use, making sure that when these products are launched, there's the right tools in place so people can access the product and the training and the supplies. And next slide, my final slide. So I talked a lot about access, rational use, need. One of the most critical things is awareness, right? So my last ask here is we need to increase awareness with policymakers, with healthcare professionals, and with stakeholders around the globe about what AMR is and what we can do. So there's a podcast series called Superbugs in You, true stories from scientists and the patients around the globe. And I would encourage you to listen to this podcast, share it with your colleagues. Each podcast has the voice of a patient, a clinician, and a researcher. And actually, episode 7 is called Silent Superheroes, Antibiotics in the Fight Against Cancer. And we have a patient who actually survived after having a bone marrow transplant, doing all the right things, still got an infection, but he talks about those challenges. And then clinicians on the front line and a researcher doing work to bring new antibiotics to market. So that I'll turn it back over to you, Sonali, and look forward to questions.
Thank you so much, Diane. You spoke so eloquently about the challenges that we're facing in this area. You talked about, we have insufficient antibiotics on the market, but then we also have overuse. And then at the same time, we also have a lack of access. So these are really the compelling challenges that we can and must address. And we're going to hear about that in the intervention of our next speaker. Our next speaker is John Kirkenes. John is the head of the Department of Cancer Research and Prevention at the Norwegian Cancer Society. Previously, he headed the section for cancer care, and he has a wide experience in political advocacy, organizational development, and leadership. John is also a board member at the Gemini Center for Sepsis Research, and he's going to talk to us now about how a legally binding antibiotic convention can provide a solution to address AMR for improved cancer care outcomes. So we are looking forward to hearing this. Please go ahead, John.
Thank you, Sonali, and thank you for the invitation and the opportunity to speak. From Anna and Diane, we have been reminded about the impact and the burden of AMR on cancer care outcomes, the need of access to effective antibiotic, and the needs for more R&Ds for new and appropriate medicine and diagnostics. Next slide. Next slide, please. But first of all, I would like to share some information about the Norwegian Cancer Society. What do we do? What is our main priorities? Our main priorities are we fund research, we do communication and fundraising, and of course advocacy and political work for cancer prevention, cancer care, and international collaboration. Thank you. Next slide. The Norwegian Cancer Society has tried to address AMR for some years by raising awareness among other cancer organizations and by gathering support from government-led initiatives to curb AMR. Here you can see a picture of former Health Minister Bent Høie and Annelise Ryel, our former Secretary General, who is now president in the NCD Alliance. We were the first patient organization who was launching an international campaign on AMR in 2017. And we strongly believe that cancer societies can make difference by representing patient voices. We have the capacity and the impact for doing policy. Next slide, please. Just a few words about Hanging by a Thread. This is an AMR exhibition which was launched in Oslo, and it has been a part of the World Antibiotic Awareness Week since 2018 in Copenhagen, in Stockholm, and later in Brussels. by a WHO meeting. We have a formal partnership with WHO Regional Office for Europe, where our society is supporting the work of AMR using the impact of cancer patients to show the adverse effect on AMR at global health. As part of the collaboration of our exhibition was planned to be set up in events in Geneva, New York, Moscow last year, but this not happened because of the pandemic. So we were sorry for that. Next slide, please. And that's the point I wish to talk most about. Our latest effort, and what I wish to raise here today, is a campaign coalition. We are working to mobilize people in all countries to urge the governments to initiate and conclude negotiations for global treaty on AMR, a global civil society campaign that can make things happen by urging states to take initiative to negotiation for a new antibiotic convention and monitor state supporter. With the support of 10 civilian society organizations from various sectors, such as health, environment, development, animal health, and agriculture, we have started a national coalition and wish to expand as soon as possible to an international coalition. Next slide, please. The successful national measures Norway has taken, including reducing antibiotic use in the health and the food sector, will be in vain if we do not gain control of AMR globally. This problem of mis- and overuse of antibiotics must be solved at an international level. Political work has been done on the topic for several years, both in the WHO and in the UN, but in our opinion, it has failed so far. We think a new antibiotic convention and a binding international framework that provides stronger incentives for the sustainable use of antibiotic is needed. Achievable and likely the most effective long-term solution to the AMR problem. Next slide, please. And we think that the political work, the timing of the political work on the national framework is probably very good. And there is a strong political focus on global infectious diseases and the importance of prevention and preparedness. This summer, there was a cross-party support for the international framework for antibiotics in the Norwegian parliament. But no government can effectively address the problem alone. There is a need for a global governance mechanism that effectively incentives states to curb misuse, overuse, and ensure a most equitable distribution of antibiotic globally. At the World Health Summit late October, Dame Sally said that AMR had to become part of the new pandemic treaty that is to be discussed at the special World Health Assembly session later this month. To sum up, we need to collaborate on innovation, next slide please, new funding mechanism, and better and more equitable access to all. We strongly think there is a need for an overarching legal framework, and civil society has to take an important role in bringing this forward. Thanks for the opportunity to present this initiative and our campaign coalition. Thank you. Back to you, Sonali.
Thank you so much, John. That was very interesting to hear, and thank you for talking about the opportunity. It's funny to talk about COVID-19 pandemic as an opportunity, but indeed it has been an opportunity for us working in global health to really show how important global health is, and here to talk about the challenges we face with infections and how critical it is to reduce AMR as a public health threat. To that end, it would be very interesting if those people participating in here, so our audience and participants in this, wanted to give any views or make any comments, please do so in the chat box. And if you want to speak, then please indicate that, and my colleagues who are monitoring the chat will be able to point me to you. But I think we can certainly have a discussion about views on that and how that efforts can be supported. But in terms of some questions, I will have a quick look. I see some comments coming through, but we do have some questions. I certainly do have some questions. So I think if I may, while we're waiting for some people for you, don't be shy, listeners, please do, let's make this, we have some time left. It would be really nice to have a discussion. So please don't be shy and share your experiences. I know that some of you are working on awareness campaigns yourselves. But I think, to start with an immediate question, let me start then with you, John. So, you talk about this, this globally binding treaty. So, I mean, how can we as a cancer community work together on a global scale? What do we need to do to make something like this a reality? Or is it really about advocacy? Is it about the awareness campaign? What are the sort of steps you would see that us doing?
Thank you, Shonali. I think our strength is that we are good to mobilize. We are good to advocate and to communicate. First, we need to see progress in global policy work related to antibiotic resistance. Concretely, we need a critical mass of states to come together and start negotiations on a global treaty to address the antibiotic resistance, as I said. History shows that global treaties can, if well crafted, help preserve global common goods. The cause of new antibiotic treaty is strong, but we need to act now and to make it happen. Second, we need to mobilize the civil society around this call, and we must intensify our efforts to communicate and advocate for change. That's a short for that.
Thank you, John. But I just see also a question coming through from Mark Lodge here. Will we be discussing the overuse of antibiotics in farming and animal husbandry? I think also, Anna, you may have some views on this, but it's really beyond, the issue, the problem of AMR is bigger than the health. I mean, it's really manifests in health, doesn't it? But it's really about working in that multi-sectoral way. Will this convention cover these areas, John?
Yes, it will cover this area, and we are working with a project description with agriculture, with health, with the One Health perspective, with the animals organizations as well. So I think that's the strength that we have to mobilize across sectors, and we have to mobilize on a global level. So of course, yes, this is not, and we could use, as I said, like cancer organizations, like the voice of the patients, because everyone is affected somehow with cancer, and we have a strong voice, but we have to do it together with different sectors. Thank you.
If I just may jump in here,
yes,
because this is kind of one of our key points in REACT also, like this lack of patient societies per se. There is some like superbugs, super moms against superbugs, and students against superbugs in Africa. So, but it's very, very minimal compared to most other diseases. And this is because antibiotic resistance isn't a disease. It is something that affects a lot of different diseases, as we've been discussing, sepsis, but also urinary tract infections that cancer patients also can get, pneumonia that also it affects cancer patients, etc. And of course, a lot of range of other things that might be less relevant. But I think that bringing these stories to life, communicating about and gathering information, whether it be data, which is publishable in a more scientific way, or highlighted as really like, this is the real world situation right now for cancer patients, what is being done about it, and to form this type of kind of coalitions of governments that are willing to drive the issue. I mean, we have now in the EU a great opportunity within the Beating Cancer mission and the kind of EU's Beating Cancer plan, and we raised this question also to Stella Kyriakides and others within the Commission, like how they handle it. And some members of the European Parliament have taken it up, but it's like such a minimal thing, and it needs to be kind of walked in all the time. And I think their cancer societies can do a really good job because you know how to do advocacy.
Yeah.
And I think that's really where we want to see it. And just on the subject of a treaty, if I may, just 2 seconds.
Yes, just quickly. And I see a couple of ones. And there's also, if you're going to talk about that, there's another question that's also, we will go in the order, but about, again, the animal husbandry, the animal issue of
I'll mention that then as well.
So if you, yes, go ahead.
So on the subject of a treaty, we completely agree we need kind of legally binding global governance rules for antibiotic resistance. Obviously now everyone's talking about the pandemic treaty, which is being discussed in the end of November at WHA, which also in some forms should contain not AMR as a whole, but parts of it. Like you have the zoonotic component, which is transfer between humans and animals, which is part of that question about like how do we address also overuse in animals, so that can be reflected. We have the question of how we develop new drugs, but also how they're being accessible to everyone in need for the next pandemic, if we consider antibiotic resistance a pandemic of sorts, etc. So I think that there's a lot of overlap between different types of pandemic, whether they be viral or bacterial, that needs to be regulated at a global level, agreed to among states. And I think this coalition of countries that support this idea, whether it's an AMR treaty as such or as part of the upcoming pandemic treaty, something needs to be done.
Thank you very much for that and for addressing the agriculture. I know there's a lot more we can say about that and think about that. Let's see if we can get back to that. Huma Jafar, you have your hand up. Go ahead.
Thank you for giving us this opportunity. I would like to add a few things. I am working in a center as pediatric oncologist where we treat over 2,000 patients every year, newly diagnosed cases. I think one basic issue, I think we can start smart. I mean, if we can choose the right antibiotic, empirical antibiotic, that's fine. But when it comes to a quick review after 48 hours, that's what we're
You're breaking up.
Yeah, I mean, we don't know.
Yeah, okay.
We don't really consider when to start. Can you hear me now?
Yes. Yes.
Can you hear me now?
Yes, go ahead.
So that's what I was, okay. So that's the area. I mean, we start the empirical treatment, but we do not really review that what next. I mean, when to start, when to switch, and do we need to really stop it at all or switch to oral antibiotics or maybe change altogether? So based on clinical response and the labs we sent initially. Second thing, I think one more thing we are talking about at our efforts at local level, national, and then globally, I think we still need to convince the physicians actually. For example, I can point out a simple trend we saw, the use of azithromycin in COVID. I mean, where you just think of COVID, you start taking azithromycin. So that's what we did. So I think that's a trend where Can you hear me, Sonali?
Yes, you're coming in and out, but yes, just we've got you back. Yes.
Quick. So I think that's the area where we need to work, where low middle income coming on, in fact, in the developed countries. So this is one thing I think we need to, and then obviously we need to change the trend of the society where people do not get satisfied if you don't prescribe antibiotics. So I think we are just the beginners. What to talk next, national levels or globally. I think being in Pakistan, I can tell you, I cannot satisfy a mother. I mean, I'm a pediatrician. I cannot satisfy a mother if I just don't write down a big list of drugs for the child. So we have to change the thought process actually. And where we think that antibiotic is the solution of everything.
Exactly.
So, I mean, that's what I really wanted to add.
Huma, thank you so much for those thoughts. And we heard those points. Those are really important points. And we have, I think this is the point really of the awareness campaigns that we're trying to do. And actually,
sorry, Sonali, let me add one thing.
Yes.
And if you ask me if I if I conduct a survey, let me tell you, I can tell you, more than 50% of the physicians in my country or the institution, they don't know the concept of antimicrobial resistance. Would you believe that? So, I mean, what are we talking about? We don't have the basic concept. And I let me admit, when I joined the course, a lot of things I made myself very clear after joining this course. And I'm really thankful I got an opportunity to attend this course. So, I mean, lots of areas where we really need to work, because that is not something which is going to affect us. That would affect everyone in the whole world, I would say. Thank you.
Thank you so much for your point and your passion on this. I think it's absolutely key, and you've highlighted some key things we need to do. We need to also work with our fellow health professionals as well as with patients. But just on the issues that you've mentioned, I think I'm going to hand over to Diane, because she was really nodding and I think agreeing with some of these clinical difficulties. And I think, again, going back to the point of the importance of diagnostics. So Diane, over to you in response to what Huma has said.
Sure, thanks. Yeah, I agree with him on that. One of the bigger challenges is how do we change behavior of physicians? And that may be one of the hardest things to do. And how can we best have people apply best antibiotic stewardship guidelines? And those differ globally. And there's a lot of work being done around antibiotic stewardship. And I think, and from a BD perspective, we support programs for on-ground training within country, so that when we're deploying new technologies, we're also providing training for antibiotic stewardship. And many diagnostic companies do that. That's not a BD thing specifically, but we do find that as a critical element. And then partnering with other organizations to help do that clinician training as another area that we focus on. But we completely agree that, you know, if we're going to do the work of doing a test and getting a result, then, you know, let's go ahead and get that antibiotic changed. It's a challenge, but we know it can be done with the right education.
Okay, thank you.
And let me ask one thing.
Yes.
If you talk about the data, I mean, can we have some guidance actually that how can we assess and sort of maybe a quality improvement or something that how can we assess, I mean, which way we are leading to? How can we assess that what are we doing? Just to get an idea the way we do stand right now to talk about antibiotics use.
Okay,
I think
I'll hand over to you, Anna, but also I would ask you then to take that and also the question that's posed by Rania, which is also part, I think, similar to that question, which is, you know, can I have a clearer answer about how much AMR is relevant to cancer patient as opposed to their compromised immune system? I think, is it too complex to define if they can be at sepsis risk from AMR or unchecked infection that was not addressed by antibiotics on time and move therefore to the risk of sepsis? I think it's quite difficult to unravel all of those things, but I think we're collecting data on infections in cancer patients. But perhaps you can look at Rania's question, but also answer those two things together. Anna, sorry to put you on the spot.
Yeah, I wasn't sure really what the gist of the question is. I mean, it is very complex about how relevant is it. Like, I would say infections are probably very, very relevant for cancer patients, and resistant infections even more so than a healthy person. So I would certainly say that it's super relevant. But I think also maybe cancer societies can go together with others, like diabetes associations, other NCDs, like Sepsis Alliance, etc. So I think there's a way to collaborate also. And on the question of like, how can we, on a national level, get together, I think one of the simplest ways would be if countries were to set a national target for the antibiotic use in humans and in animals for that matter. And that needs to be defined as individually per country. It can't be the same. Some countries might have to increase their antibiotic use and some will decrease it or do both at the same time. But what setting a target means is that you'll have to investigate like what the pattern of diseases look like in your country. How are we using antibiotics now? Are there some clear areas where it's very safe to actually reduce antibiotic use without risking underuse instead? And then they can be held accountable to it. And I think that's one of the reasons why Sweden has actually been so very successful, that we have had this target, and we reached it this year with COVID actually for the first time. We had it for a long time. I know Norway's also set a national target now. So I think because it leads to also a lot of different investigations, you need to be able to measure your target, you need surveillance in order to understand which infections you can and can't treat. You need to do diagnostic testing of the resistant bacteria, etc. So I think that would be like an advocacy point that you can push towards your government.
Thank you very much. Thank you so much. I think just moving a little bit on beyond some of the clinical aspects of AMR presentation in cancer patients, and I think, you know, I think there are guidelines, or there will certainly be a lot more emphasis on this as we go through, certainly in UICC's own awareness campaigns going forward. I think it would be, it's important also to talk about, you know, how do we see, what do we see are the ways in which we can join with other communities that have been working on AMR. And I'm thinking again about, and it would be interesting to hear also from Diane, because, you know, you work across different health communities and you work with infectious diseases, but also non-communicable diseases. And I don't, you know, seeing again AMR in cancer patients are very much vulnerable to AMR, to infections and then to AMR. But again, another siloed approach would not necessarily be helpful. So what do we need to be doing to work with other communities, other health areas? Are we doing that in this area? If not, why not? And how can we do that better?
Sure, so I'll take that first and then others can chime in. I think that is currently an area where we can improve upon, where we, I always say we talk to our AMR bubble, right? There's those of us that are in our AMR space and we talk to each other quite effectively. However, we haven't successfully found ways to engage with other organizations. And part of that is because AMR covers so many different areas. So if you think of the tuberculosis and resistant TB advocacy groups, very strong, very passionate, and they are a part of AMR. I mean, multi-drug resistant TB is a big part of the AMR burden. You think of sepsis, you know, the sepsis organization is also very passionate, and the only way to resolve bacteremia is with an antibiotic. So, you know, so they also are very passionate. So I feel like right now, AMR, we're a bit too vague, and we cover so many areas. It's kind of coming, how do we come together? And I think that's a challenge that we all on this call can, you know, work towards. The one thing that I have found to be successful from the Antimicrobial Resistance Fighter Coalition is we always bring the voice of a patient, a researcher, and a clinician. We purposely always make sure we have all three people at the table for any conversation, because that does allow then those people listening to find something that they can connect to and then make a change. So that's really, you know, maybe the one thing we can think about is when we talk about AMR and advocacy, making sure we have all the voices at the table when we're trying to influence our stakeholders and policymakers.
That's great. So you always bring together patient, researcher, and clinician in your discussions. Well, that's a very interesting approach. Thanks for sharing. Does anybody else have a comment? John, do you have a comment also on working with other communities? And have you done that in the Norwegian Cancer Society? Have you worked with, for example, other infectious disease societies on this topic, and in what respect, and in terms of lobbying, etc.?
Yes, as you said, I'm part of the Gemini Center for Sepsis research, and we have different groups. But this is what we are trying to do now at the national level bringing together different organizations. So we have dialogue, and we are writing a project description together, where we are trying to put everything of these issues in. So yes, and we have also within the national NCD with diabetes and heart and stroke and so on, we have this issue on the agenda. So we are working with other organizations on this level, at national level first. Thank you.
Thank you. I'm not sure, Huma, if that's an old hand or a new hand.
I just want to add one thing. I mean, it's so relevant to cancer patients, actually. I can tell you the major reason behind mortality in my center is sepsis, and where we get bugs which show pan resistance. And at times we are not left with any other option except for colistin. So that is what is happening quite frequently, and we are losing patients of acute lymphoblastic leukemia standard risk just because of sepsis. So AMR is there. I mean, that's the major thing we are facing, the basic challenge we are facing. If someone asks that, how is it relevant to cancer patients? Thank you.
Thank you very much, Huma. Rania, you have your hand up. Go ahead. Do you have a question, Rania?
Yes. Thank you for what discussed so far. The question is, because I had some questions in the chat box, but this is something different. In metastatic patients, some of the symptoms for targeted therapies or advanced drugs are 80% similar to sepsis or severe infection. And they are most of the time, and I'm not talking about mistakes in treatment, it's just a casualty that happens all the time from my observation as a patient advocate, that because 80% of these symptoms are similar, they are considered acceptable, and worst yet can be treated as the side effect of the drug, like diarrhea, vomiting, being confused, or lack of sleep when appetite, or nausea. So they can give them a drug to try to alleviate or make them comfortable not having these diarrhea. At the time, it is an infection, not from the side effects. So I guess the question is how to address this delicate issue. It takes many lives every year. There are sepsis alliances that raise awareness about this. There are cancer associations that raise awareness about metastatic or advanced cases. But we need really to merge these efforts, because it's confusing, and it's not a hot potato game like accusing who is responsible, because lives are impacted. So I just wonder what it takes. And on our part, like as patient advocates associations, we raise awareness, and it makes a difference to be alerted about these symptoms. But what else can be done? It's just I'm wondering.
Thank you. Thank you. Does anyone want to quickly address that? It's a very big question. And I think, it's difficult to, well, first of all, we have 2 minutes left, but I think, there are national guidelines, there are guidelines. So do have a look at what guidelines are out there that have been added in the chat box. But also, I think it also goes down to the rational, correct use of antimicrobials. And again, going back to Diane's point around correct diagnosis and understanding what infection you are dealing with as well. So Diane, I'm going to hand over just quickly to you to very quickly respond to that point.
Sure, yeah, I think the technical part of that is beyond my skills, but I would say that the best use of diagnostics is critical. And I say that with a recognition that they're not always available. So access, as we talked about, getting the right diagnostics in the right locations is a critical part of managing, helping patients, as well as using our antibiotics most effectively.
Yeah. I think this is a longer conversation, and certainly one to discuss with a group of clinicians exactly on some of those issues. We are looking at producing some evidence on through a scoping review on the impact of AMR on cancer outcomes, and we hope to come out with that next year. So do keep a lookout for those documents. Anna, your hand's up for a last comment before I need to close. You have 1 minute left. Thank you.
Yes, thank you. I was thinking actually, a practical thing that could have some impact in the advocacy could be what the Longitude Prize did in the UK, to ask actually cancer physicians about their view on how antimicrobial resistance affects their patients. It's obviously not like completely scientific evidence, but it's quite impactful to have like 100 cancer physicians all saying like, within 10 years, we can't treat cancer patients the way we do today if nothing's being done. So in kind of the absence of hard data, I think maybe if that was done in a number of, and especially in LMIC countries, that could have a really huge impact and also help maybe form this coalition of countries that we're asking for.
Thank you. Well, this has been a really wonderful discussion. Thank you so much for your engagement. I think we could have gone on a lot longer, and it's always great to leave a dialogue with people wanting to discuss more. So we look forward to continue these discussions. Don't hesitate to get in touch with us. Any of the us here on this call, I think the speakers may have made their contact details available in their presentations, and don't hesitate to get in touch with us at UICC. Wishing you a great day, and thank you again for joining this session. Goodbye.
Thank you.